This is the warm-up for Rheum and Derm 8. First question, what are the normal blood pressures in the right and left ventricles? So in the right ventricle, it's about 25/5. In the left ventricle, it's about 130/10. And the last question, which primary bone tumor fits each of the following descriptions? So the most common malignant primary bone tumor of children is osteosarcoma. The most common benign bone tumor is osteochondroma. 1122 translocation is seen in Ewing sarcoma. The soap bubble appearance on X-ray is an osteoclastoma. Remember the CL for clean, like soap, and CL in osteoclast. Onion skin appearance of the bone is Ewing sarcoma. Remember onion rings and wings. And then Codman's triangle on X-ray is osteosarcoma. Remember the S in sarcoma was for sunburst, and the C in sarcoma was for Codman's triangle. All right, let's get to the lecture.
Hi everyone, and welcome to our second video on dermatology. We have a lot more skin things to talk about, so let's get going. So seborrheic keratosis. This is a common benign neoplasm. These can be flat or warty, greasy, pigmented, kind of tortoiseshell looking lesions. They look pasted or stuck on, like you could just peel them off, but you can't. Microscopically, you see proliferation of keratinocytes with the characteristic keratin-filled cysts, and you can have horn cysts as well. Overall, these are more common in older individuals, and while they can appear en masse in association with underlying malignancy in the GI tract, for example, the lesions themselves are harmless. These are not premalignant lesions, they're a cosmetic problem. Okay, now we're going to talk about some pigmented skin disorders, starting with albinism. So in this condition, there's a congenital lack of melanin pigment, and the oculocutaneous type involves the skin, eyes, and hair, and is inherited in an autosomal recessive pattern. The mechanism is a mutation in one of multiple described genes in the melanin synthesis pathway, commonly a tyrosinase enzyme responsible for the first step in that pathway. These patients have a normal number of melanocytes, but decreased melanin production due to these enzyme deficiencies. And you'll hear more about this in the amino acid disorder video. Next is vitiligo. This is much more common than albinism and is acquired rather than congenital. So with this condition, sections of the body develop complete depigmentation. So you'll see a decrease in the number of melanocytes. And again, this is different from albinism, for which there's a normal number of melanocytes but decreased melanin. Vitiligo is a decrease in the number of melanocytes. The cause is not known, but appears to have an autoimmune component and is associated with other autoimmune conditions like type 1 diabetes or Addison disease. Genetic factors seem to be involved as well. Oxidative stress and even triggering by viral infections may contribute. Okay, melasma. This is the last pigmentation condition we'll discuss. This is acquired and only patchy, like vitiligo, but it's a dark skin discoloration rather than a lack of pigmentation. And patients will have dark, irregular, kind of well-demarcated hyperpigmented macules, usually in sun-exposed areas like the cheeks or the lip, and they develop gradually over time. It's particularly common in pregnant women and those taking oral contraceptive pills or hormone replacement therapy. In fact, we call it the mask of pregnancy when we see it in a pregnant woman. It's pretty common. Around 25% of pregnant women will get it. And the pathogenesis isn't really understood, but probably is related to stimulation of melanocytes by estrogen and progesterone. And in many cases, the patches will spontaneously resolve over several months. Okay, let's go to some infectious skin conditions, starting with impetigo. Impetigo most commonly is caused by Staph aureus, but group A strep, strep pyogenes, can also be causative. This is highly contagious. The lesions are honey-colored and crusting and are common around the lips and nose of children. You can treat with topical mupirocin or retapamulin if the outbreak is mild. But for more serious infections, you can give dicloxacillin or cephalexin orally. Okay, cellulitis. This is another bacterial infection, this time of the dermis. It's painful and tender to the touch, and it can rapidly spread, and you'll see a ton of this in the hospital. Subcutaneous tissues can also be infected. So the most common pathogen here is strep pyogenes, and less often Staph aureus can be causative as well. And if the cellulitis is non-purulent, in other words, no associated abscess, and you don't suspect MRSA, then you can treat with oral dicloxacillin or cephalexin. And if you suspect MRSA, then consider using trimethoprim sulfamethoxazole or clindamycin. Necrotizing fasciitis. This is a very serious and scary infection. The infection involves the deeper layers of skin and subcutaneous tissues, and what makes it dangerous is that it can quickly spread across the fascial plane, and it's commonly caused by anaerobic bacteria or Strep pyogenes. The skin here is very tender, and also the tenderness tends to extend beyond the visible area of cellulitis on the skin. You can feel crepitus from the methane and CO2 produced by the bacteria. Treatment is immediate surgical debridement and IV antibiotics like a carbapenem together with clindamycin. Staphylococcal scalded skin syndrome, SSSS. So as the name implies, this is caused by Staph aureus, and the syndrome is induced by epidermolytic exotoxins. So exotoxins A and B are released by Staph aureus, and it destroys keratinocyte attachments in the stratum granulosum. Patients will get fever and a generalized erythematous rash with sloughing of the upper layers of the epidermis. This is most often seen in newborns and children. And treatment includes antibiotics to cover staph, like nafcillin, oxacillin, or vancomycin if it's MRSA. Hairy leukoplakia. These are white patches on the side of the tongue. They're painless plaques that cannot be scraped off. They're caused by EBV, Epstein-Barr virus, in immunocompromised patients. It occurs almost entirely in HIV-infected patients. And don't get this confused with regular leukoplakia, which is a lesion in the oral cavity, not necessarily on the sides of the tongue. But it's another flat white patch that can be mistaken for thrush or lichen planus. 5 to 25% of leukoplakias are precancerous. Okay, now on to blistering skin disorders, starting with pemphigus vulgaris. This is an autoimmune chronic blistering disease, and here we see antibodies against the desmosomes. What do the desmosomes do? They connect epithelial cells together. They do not connect the cell to the basement membrane. What was the molecule that connects epithelial cells to the basement membrane? Hemidesmosomes. So here we're talking about the desmosomes. So anti-desmosome or anti-desmoglein antibodies are the antibodies here. Patients will get painful blisters, also described as flaccid, so they look wrinkly and droopy, not full of fluid and tense. And patients also can have oral lesions, which can differentiate pemphigus vulgaris from other skin blistering diseases, so that's a good one to remember. The diagnosis is suggested if there's a positive Nikolsky sign, which is separation of the epidermis upon manual stroking of the skin. But the gold standard for diagnosis is with a punch biopsy and then direct immunofluorescent staining, which will show antibodies in a reticular pattern. Microscopically, you'll see acantholysis, which is the loss of intracellular connections, which again is due to the loss of the desmosomes. Okay, another one of our PG-13 rated mnemonics. This one came from a student. Pemphigus vulgaris, damn. Damn is a vulgar word. Desmosomes, acantholysis, mouth, Nikolsky sign. Okay, now let's talk about bullous pemphigoid. So it's autoimmune with antibodies against hemidesmosomes, which connect the cells to the basement membrane. I think we've said that a few times now. You'll see eosinophils within a blister. It's similar, kind of similar clinically to pemphigus vulgaris, but tends to be less severe. And bullous pemphigoid will have a negative Nikolsky sign, and also it spares the oral mucosa. So remember that I said the oral lesions are only associated with pemphigus vulgaris. A memory tool used for the antibodies is pemphigoid, which is a longer word than pemphigus, much like hemidesmosomes is a longer word than desmosomes. Another mnemonic that might help is BPH, bullous pemphigoid, hemidesmosomes. Okay, dermatitis herpetiformis. This is a chronic blistering disease, and despite its name, it has nothing to do with the herpes virus. It's named this because the inflammation has the appearance of herpes lesions, like little itchy vesicles, and patients will present with these really intensely pruritic papules and vesicles. Direct immunofluorescence studies will show deposits of IgA in the tips of the dermal papillae, and it's associated with celiac disease, and the symptoms can worsen with the amount of gluten ingested. So a pruritic skin disorder associated with celiac disease, think about dermatitis herpetiformis. Moving on to erythema multiforme. So this is an acute onset rash which is most studied in association with HSV infection, that's herpes simplex, but other factors also contribute. The cause is not completely understood, but it may be related to deposition of immune complexes in the superficial microvasculature of the skin and oral mucous membranes. It usually follows some infection or drug exposure, and it can vary from a very mild rash to a severe life-threatening form that's like Stevens-Johnson syndrome. And patients can present with the distinctive target-shaped lesions, but also with macules, papules, and vesicles. The rash is often pruritic, and again, this is commonly due to HSV infection or a drug reaction. Okay, then Stevens-Johnson syndrome. This is a very severe and terrifying skin condition where cell death leads to the separation of the epidermis from the dermis. This is thought to be a hypersensitivity reaction that affects not only the skin but the mucous membranes as well. So the symptoms of Stevens-Johnson include fever, bulla formation, necrosis, sloughing of the skin, and unfortunately a high mortality rate. This is one of the few dermatologic emergencies. And even more severe form of Stevens-Johnson syndrome is toxic epidermal necrolysis, or TEN. So Stevens-Johnson and TEN are essentially the same disorder, just differing magnitudes. So with TEN, at least 30% of the body surface area is sloughing and detaching. So if you have at least 30% of the body surface area sloughed off, that's TEN, toxic epidermal necrolysis, rather than Stevens-Johnson syndrome. And there are multiple drugs implicated in the cause of Stevens-Johnson. Seizure medication, sulfa drugs, penicillin, and allopurinol are some examples. All right, here are a few miscellaneous disorders. Lichen planus. So this is another disease of the mucous membranes, and the lesions look like lichens, that grow on trees, hence the name. So it's thought to be due to an autoimmune process with an unknown trigger. So when you think of lichen planus, you need to think about the P's. So these lesions are pruritic, purple, polygon-shaped, papules, and plaques. On microscopic exam, you might see a sawtooth pattern of lymphocytes at the dermal-epidermal junction, and it's associated with hepatitis C. So, hepatitis C, lichen planus. Actinic keratosis. These are growths of thick, scaly, crusty skin. They're sometimes easier to feel than see. They're like sandpaper. And unlike seborrheic keratosis, those stuck-on lesions we talked about earlier, actinic keratosis are precancerous. Untreated lesions have up to 20% risk of progression to squamous cell carcinoma. They occur more commonly in fair-skinned people who get a lot of sun, and these need to be treated. So one drug that can be used for actinic keratosis is 5-fluorouracil, or cryoablation with liquid nitrogen can also be used. Acanthosis nigricans. This is a brown or black, poorly defined, velvety hyperpigmentation of the skin. And this is due to hyperplasia of the stratum spinosum. It's most commonly seen in the lateral and posterior folds of the neck, or the axillae, or the groin. And it can be associated with hyperinsulinemia, like with type 2 diabetes, and this is really common actually. But it also can be seen with visceral malignancies. So if you see a patient with new acanthosis nigricans, you definitely want to screen for diabetes. And if the patient's older than 40 years or so, you might think about a visceral malignancy as well. The skin lesion itself is harmless, just a sign of something else going on. Okay, erythema nodosum. This is a patch of inflammatory lesions of subcutaneous fat, which look like tender red nodules or lumps on the shins bilaterally. These are most common in young people between the ages of about 12 and 20 years. And erythema nodosum is commonly associated with sarcoidosis. And then you can also see in other disorders like histoplasmosis, coccidiomycosis, TB, leprosy, or group A strep infections like strep pharyngitis. And the lesions typically resolve spontaneously within 3 to 6 weeks. Okay, pityriasis rosea is an interesting one, an acute exanthem, probably viral. It starts with a herald patch, usually on the trunk or the back. It doesn't have to be on the trunk, like in this patient, it's on the arm, but classically it's on the trunk or back. It's 2 to 10 centimeters, red and oval shaped. And then days later, you see a more generalized rash of multiple small patches that tend to follow along rib lines. So you get what looks like a Christmas tree distribution. And then it remits spontaneously over 4 to 6 weeks and is benign. Sunlight can actually help the lesions resolve. Okay, before we go to cancer, let's do a quick game show to review some of these. So we have blisters, positive Nikolsky sign, and desmosomes, That's pemphigus vulgaris. Then premalignant, sandpaper-like, treat with 5-fluorouracil, that's actinic keratosis. Honey-colored crusting lesion, highly contagious, caused by staph or strep, that's impetigo. Christmas tree distribution, herald patch, sunlight improves the rash, that's pityriasis rosea. Blisters, negative Nikolsky sign, hemidesmosomes, that's bullous pemphigoid. Associated with hep C, sawtooth infiltrate of lymphocytes, pruritic purple papules, that's lichen planus. Intensely pruritic, IgA in tips of dermal papillae associated with celiac disease, that's dermatitis herpetiformis. Okay, let's quickly move on to skin cancer. Definitely a high-yield subject. This is 4 or 5-star topic. So the order of commonality of the skin cancers is basal cell, then squamous cell, and then melanoma. And then the order of metastatic risk is reversed. So melanomas have by far the most metastatic potential, and then squamous cell, and then basal cell. Squamous cell carcinoma, very common, estimated to be about 20% of non-melanoma skin cancers. Squamous cell cancers are going to appear on sun-exposed areas, typically the hands and face. It's locally invasive, but rarely metastasizes remotely. And what you'll see is a scaly patch or plaque or an ulcerative red lesion. Histologically, there will be dysplasia of the keratinocytes with the distinctive finding of keratin pearls. Basal cell carcinoma, again, these occur in sun-exposed areas, and basal cell cancers will have a rolled edge appearance with a central ulceration, or can be pearly-looking papules. And along with those pearly papules, you might see telangiectasias. And microscopically, you may see palisading nuclei. And melanoma is the last skin cancer we're going to talk about, and the most scary. Like the others, it's associated with sun exposure, although it can occur in non-sun exposed areas as well. So what are the ABCDs of melanoma that would increase your suspicion for the lesion? A is for asymmetry, B is for border irregularity, C is for color, meaning multiple colors in the lesion, and D is for diameter. If the diameter is bigger than the head of a pencil, then it's suspicious for melanoma. Under the microscope, you'll see nests of melanocytes that fill the dermis and obscure the epithelial dermal junction. And the depth of the tumor correlates with the risk of metastasis. And so this is really important because when you're evaluating a skin lesion you think might be melanoma, you want to get an excisional biopsy, or at least a punch biopsy, and not a shave. If you do a shave biopsy, you're not going to be able to assess the depth of the tumor. Okay, pause the video and look at your end of session quiz and your study guide, and then we'll go through the answers together. What are some of the hallmark features of necrotizing fasciitis? The features are rapidly spreading cellulitis, and cellulitis that has tenderness beyond the red border, indicating an underlying fascial infection, and then subcutaneous crepitus. And what organism causes this infection? It's either Strep pyogenes, group A strep, or an anaerobic bacteria. And what pathogen causes painless white patches on the tongue that cannot be scraped off? The pathogen is EBV, and the condition is oral hairy leukoplakia, commonly associated with HIV infection. Which skin disorder matches each of the following statements? The pruritic purple polygonal papules is lichen planus. Pruritic vesicles associated with celiac disease is dermatitis herpetiformis. Antibodies against hemidesmosomes is bullous pemphigoid. Antibodies against antidesmosome, pemphigus vulgaris. Keratin-filled cysts are seen with seborrheic keratosis. Sandpaper lesions and predisposition to squamous cell cancer is actinic keratosis. Honey crusting lesions that are common about the nose and lips is impetigo. And histology shows palisading nuclei is classic for basal cell carcinoma. Now we have a few rapid fire facts. Keratin pearls on the skin biopsy are a feature of squamous cell carcinoma, and the most common malignant skin tumor is a basal cell carcinoma. All right, that's it for Rheum and Derm 8.